Hi everyone, my name is Jessica Yagrassi, and for my evaluation of clinical practice course, I decided to take a look at safety planning and how it can be used to prevent psychiatric readmission in adolescents. I'm currently interning at Ellis Hospital, which is located in Schenectady, New York. Ellis offers a wide variety of services, including adolescent mental health treatment. That unit serves children from the ages of 4 to 18, which come from a wide variety of areas, extending from Poughkeepsie to Canada, from the border of Vermont all the way to Syracuse. The focus of the unit is to provide short-term intensive treatment for teens in crisis. Many of them are diagnosed with disorders such as depression and anxiety, bipolar, ADHD, eating disorders, and severe behavioral conduct disorders. The typical length of stay on the unit is 5 to 7 days, but it can be longer if needed, depending on the child's diagnosis. Treatment team on the unit includes 2 psychiatrists, several nurses, 4 social workers, certified teachers, recreation therapists, and mental health aides. Presently, once the child is on the unit, they're able to engage in several groups. When it's time for discharge, all of the stakeholders, so the child's family, the child, private therapist, school members, community-based agencies, residential treatment facilities if they're involved, and others, such as CPS, get together to discuss the long-term treatment goals of the child. A treatment plan is created with the child where they identify their triggers, internal and external coping skills, social supports, and the one thing that they identified as making their life worth living. The plan is created with the child and is then reviewed upon discharge and is given to the child as something they can reference to when in need. According to the National Suicide Prevention Hotline, in 2005 alone, over 40% of suicide victims had a known psychiatric diagnosis, such as bipolar, schizophrenia, depression, at the time of their death. These are all diagnoses that we see very commonly at Ellis. Children who are admitted onto the B3 adolescent unit at Ellis suffer from diagnoses, which significantly increases their risk for suicidal behaviors due to mood instability, hopelessness, impulsivity, low self-esteem, and high exposure to abuse and trauma. But unfortunately, regardless of the coordination of treatment that occurs leading up to discharge, up to 13% of all adolescents are readmitted shortly after discharge, within 30 days, from acute psychiatric units, such as the one that Ellis offers. As a result, the hospital is not only fined by insurance companies for failure to provide adequate care, but patients also suffer as a result. The overall goal for the study was to determine if the overall safety plan that is in place is effective and what can be changed in order to avoid 30-day readmission. A purposive sampling procedure was used to recruit participants who met the following criteria. They have to be employed in a profession on the inpatient adolescent unit at Ellis. They have to be employed on the unit for at least 6 months and have to be at least 18 years of age. A qualitative approach was utilized to gather information regarding the effectiveness of the current safety plan that is being implemented. Participants were interviewed individually, and they were presented each a copy of the blank safety plan that is administered to each patient, which will be shown on the next slide. Participants were then asked to analyze the safety plan in terms of cultural diversity and clarity of the language used, along with thinking of suggestions of ways to improve the safety plan to avoid rehospitalization. As you can see here, this is the current safety plan that is currently implemented at Ellis, which was established in 2008 by Brown and Stanley. This safety plan is used by the Suicide Prevention Association and is completed by all patients with the assistance of the social worker during his or her discharge meeting. As you can tell, step 1 is for the client to identify their warning signs. Step 2 is to identify internal coping strategies. Step 3 is to identify people in social settings that provide distractions. Step 4 are people whom they can ask for help. Step 5 includes listing professionals or agency that can be contacted during a crisis. And step 6 is identifying what makes the environment safe. At the very bottom, the client will identify one thing that is most important to them and what is worth living for. Results. Each participant was issued a copy of the present safety plan that each patient receives upon discharge. The sample size was composed of 13 people, 4 males and 9 females, including unit social workers, mental health aides, and psychiatrists. 7 of the 13 participants suggested editing the safety plan so that it can be more accessible. All participants felt that the safety plan was appropriate in terms of cultural diversity and language used, as the safety plan has already been approved by the Suicide Prevention Resource Center. 3 staff suggested making the safety plan more pocket-friendly and accessible during times of needs. Suggestions included turning the safety plan into a name badge so that the clients can wear it around their neck. Also, they can make the safety plan onto an index cards that will later be laminated, allowing it for it to be carried in either a pocket, wallet, or purse without becoming crumbled or lost. 4 of the other staff suggested implementing a program that is similar to a new trial program that is being executed by the insurance company CDPHP. This program is known as the Community Transitions Program, a wellness program available to all those that have this insurance. It is designed for individuals that have been hospitalized and are currently receiving inpatient mental health services. Because the first month after discharge is the most challenging, without assistance, the chances of rehospitalization are the highest. CDPHP's Community Transition Program provides in-home counseling and assistance to individuals as they transition from an inpatient mental and behavioral health service to an outpatient program, greatly increasing the likelihood of successful and permanent transition. An Ellis social worker will schedule a bridger appointment, which is when a case manager from CDPHP will visit the client at home and make sure that the patient is transitioning well and is following through with their discharge plan. Although this program is new and it's still in its trial stages of implementation, it has shown an efficiency in reducing rehospitalization rates in those who have this insurance. Ideally, a program like the Community Transition Program should be implemented with everyone, regardless of their insurance company, providing clients with a clinical resource such as triage and referrals, coordination of care, and case management not only provides each with individualized treatment plans that support optimum outcomes, but also offers additional specialized resources for those struggling with things such as substance abuse and eating disorders. Combining all of the suggestions mentioned above and with the CDPHP program will greatly decrease the chance for someone to be rehospitalized within 30 days, providing better aftercare for all patients, and from the hospital standpoint, it would avoid the hospital from being fined, as what insurance companies would consider inadequate care. Future research should further look at programs such as the one implemented by CDPHP to analyze how supports such as in-home case management, aftercare post-discharge, and specialized counseling can prevent rehospitalization on an inpatient psychiatric unit. Additionally, research should focus on how difficult it is to adhere to a rigorous transitional program in terms of time required, and ways to make it so that everyone has the ability to access such services, regardless of the type of insurance that they have.